welcome to the Probio Professional Discovery Academy web seminar titled Probiotics and Liver Disease. This is the second installment of a four-part series that is entitled Medicine or Snake Oil? Is there a role for probiotics in your clinical practice? My name is Dragana Skokovic-Sanjic. I'm your moderator. I'm a clinical pharmacist working in a primary care practice in Hamilton, and I'm the author of the clinical guide to probiotic products available in Canada and in the US. And this is why I'm involved in this project. Probio stands for Alliance for Education on Probiotics. We are dedicated to establishing probiotics as a frontline therapy for the protection, restoration, and enhancement of human health. And we are a trusted global resource for evidence-based information on probiotic products. Probio has been working hard, compiling, reviewing, and summarizing evidence on specific probiotic products and associated applications since 2008. And before we ask Dr. John Damianos to start his presentation, we'd like to acknowledge that this important education series has been made possible through an unrestricted education grant from Exegi Pharma. We appreciate their support and encourage you to join us in thanking them for bringing us together today to learn. Please remember, this event has been created for you. I encourage those who are attending the live session to ask questions throughout the presentation using the chat feature. That way it's easier for us to monitor. If you go to Q&A and put a question, I'll make sure to check that as well. And we will try to answer as many questions as possible at the end of Dr. Damianos' presentation. So for today's session, probiotics are really not new, and yet there continue to be many misconceptions. And what we find is significant lack of understanding about probiotics and by healthcare providers and consumers alike. Today's sessions, presented by Dr. John Damianos, will explore the relationship between the gut microbiome and liver disease, relevant literature, and resources you can turn to for additional information. So I'd like to introduce you to John Damianos, MD. He's a resident physician at Yale New Haven Hospital in the Department of Internal Medicine, where he is pursuing the clinician educator distinction pathway. He graduated from Dartmouth College in 2016, where he studied linguistics and neuroscience, and from the Dartmouth Yale School of Medicine in 2020. He has extensive experience in medical education, including editing several medical board review books, writing and editing questions for board review question banks, and serving on the editorial board of Elsevier Clinical Key MedEd. Clinically, he is interested in gastroenterology, specifically the role of gut microbiota in disorders of gut-brain interactions, such as irritable bowel syndrome and functional dyspepsia. His current research focuses on endoscopic techniques in evaluating esophageal dysmotility. He's also a member of the trainee faculty for Twitter Gastroenterology Journal Club motility sessions. Medical educator at heart, Dr. Damianos is passionate about evidence-based medicine, and he is thrilled to serve on the Scientific Advisory Council of Probio to help clarify, synthesize, and promote the latest research in probiotic science to both the medical and lay communities. Now that you've been introduced to our amazing speaker, let's start learning. Welcome, Dr. Damianos.
Well, thank you, Dragana, and thank you to everyone at the Alliance. I am absolutely thrilled to be here to discuss a topic near and dear to my heart, which is the gut microbiome and probiotics, and specifically their role in chronic liver disease. So we'll just begin with some objectives here. I'll briefly go into why this is an important topic and how the gut microbiome relates to chronic liver disease. And then I'll discuss the potential role of probiotics and the data surrounding probiotics for two specific conditions, including non-alcohol related fatty liver disease and minimal hepatic encephalopathy. And the last thing I'll do is I'll leave you with some resources in choosing and using probiotic products. So let's dive right into it. I want to begin with the concept of non-alcohol related fatty liver disease and the more recent developments. And I'm highlighting this one article from Liver International here that says, "What's in a name? Renaming NAFLD to MAFLD." And this harkens to a current proposal, which is to rename non-alcohol related fatty liver disease to MAFLD, or metabolic associated fatty liver disease. And what this does is two things. Number one, it renames a disease to characterize not what it is not, but it changes the name to something that better explains the pathophysiology. And so this figure here shows all of the different factors that play into the development of non-alcohol related fatty liver disease. And these include things like the metabolic syndrome, and importantly, and what we'll be focusing on today, alterations in the gut microbiota. Now, dysbiosis, or abnormalities of the gut microbiome, is an important component in the pathogenesis and the maintenance of chronic liver disease. So many lifestyle factors, diet, stress, things like alcohol, as we all know, tobacco, exercise, sleep, and many other factors impact the gut microbiota. Now, when negative factors such as poor diet, high levels of stress, toxins in the diet, alcohol, tobacco, et cetera, these have adverse effects of the gut microbiota, including decreasing the diversity. And as I always like to say, like in life, diversity in the microbiome is beneficial. There's a reduction of beneficial taxa, an increase in the abundance of gram-negative and pathogenic species, and the development of small intestinal bacterial overgrowth. All of this is associated with a reduction in healthy metabolites that strengthen the gut epithelial barrier, that impact systemic metabolism. And the endpoint is increased intestinal inflammation, increased intestinal permeability, metabolic endotoxemia, and systemic inflammation that affects almost every organ system. Now, this is a figure here from a paper that looked at microbiome alterations in NAFLD and compared those to some other components of metabolic diseases, such as type 2 diabetes and obesity. And there does seem to be a significant overlap. This other paper here characterizes particular gut microbiome signatures associated with non-alcoholic fatty liver disease in comparison to healthy individuals. And there do seem to be patterns that emerge that I mentioned before, of the decreased abundance of beneficial species, an increase in gram-negative pathogenic species, and the end point being propagation of inflammation. Now, this figure here illustrates that a little bit more, that depending on the metabolites that come through the diet or through the environment, the microbiota can be modified differentially. The metabolites are carried through the bloodstream via the portal system into the liver and can have either beneficial or detrimental effects. One particular example here is choline, which is obtained from the diet. The gut microbiota metabolize choline, which is found in red meat and eggs and fish, and metabolizes it into TMA, which is a metabolite that reaches that is converted in the liver and is associated with systemic inflammation and the development of atherosclerotic heart disease. Other microbial products and metabolites of the gut microbiota continue to promote inflammation, which eventually leads to the development of scarring and chronic liver disease. Liver disease exists on a spectrum where the end product of any chronic liver disease is cirrhosis. At the point of cirrhosis, this is the mostly irreversible scarring that occurs with the liver. Now, the insults that occur before then, including the inflammation and steatosis, steatohepatitis, can actually be reversible. And so given the increasing prevalence of NAFLD or metabolic-associated fatty liver disease and its emergence as one of the most important causes of chronic liver disease and cirrhosis in this country, there is a dire need for both patients and from a public health standpoint to not only prevent chronic liver disease, but stop it in its tracks such that we are able to reverse liver disease when it's in its earlier stages. And as we see here, certain metabolites derived from the gut microbiota, such as lipopolysaccharides, TMAO, which I mentioned earlier, have a detrimental effect and can promote this development of chronic liver disease toward the endpoint of cirrhosis, whereas other beneficial metabolites of the gut microbiota, such as short-chain fatty acids, which can be increased by dietary fiber, are anti-inflammatory and can promote the healing of the liver. So going into probiotics, as I'm sure many of us know by this point, the official definition of probiotics is live microorganisms when administered in adequate amounts confer a health benefit on the host. This figure here shows a couple of general mechanisms that probiotics have. I'll just go back one slide here. The American Gastroenterological Association, the AGA, in their technical review on probiotics included that there is accumulating evidence in support of probiotic use in liver and metabolic diseases. And in their review includes several different potential uses in liver diseases. I'm going to focus first today on NAFLD or metabolic-associated fatty liver disease. As many of us know, NAFLD is very closely associated with the metabolic syndrome. The metabolic syndrome is characterized by truncal obesity, insulin resistance, hypertension, and dyslipidemia. So earlier probiotic research has focused on various components of the metabolic syndrome. I'll go over some of these briefly. I won't go into too much detail since it's not exactly related to liver diseases. I'll focus on some of those studies later. For obesity, a few meta-analyses have found moderate and consistent benefits of certain probiotic strains for obesity. Now, if anyone here watched Dr. Quigley's lecture in the last session, he brought up some of the methodologic challenges of interpreting meta-analyses in probiotics. And I show this example here from the prior meta-analysis to suggest that we may be comparing apples to oranges in many of these studies. As you can see here, studies used various strains. Studies also used capsules, yogurt, even cheese in one example. And so it is very difficult to actually make comparisons. So it is encouraging that we see the meta-analysis showing positivity overall, but it also reminds us that we need to focus on the evidence-based strains and continue to build on that kind of research. On this line, we need to focus on well-designed randomized control trials and attempt to replicate them. And one excellent example of this are the ProMagine and Probe studies. This was a study using the Lab4P probiotic, which, as I include here at the bottom of the slide, is a mix of a few different strains. The studies looked at the effect of the Lab4P probiotic in obese individuals over the period of 3, 6, and 9 months. And there was, in both studies, a significant reduction in BMI, weight, and hip circumference that occurred at all time points compared to the control. And so it is well-designed clinical trials like these that we need to continue to replicate so that we can give good recommendations to patients. Similarly, with diabetes and insulin resistance, this meta-analysis found that there were beneficial effects in improving patients' insulin resistance, fasting blood glucoses, and hemoglobin A1C. Similarly, there is benefit in hypertension, both systolic and diastolic blood pressures, particularly in those patients who had hypertension to begin with, as well as diabetes. Dyslipidemia has similar findings. Now, moving to NAFLD specifically, there are a few trials that have looked at probiotics in these patients. Now, this is potentially one of the best designed trials. It was a small trial looking at 30 patients with biopsy-proven non-alcohol related steatohepatitis. And the formulation used here was the Dysbiosis D-Simone formulation. And I've included the mix of strains that includes here. The primary outcome was histological improvement, so improvement of actually the liver on microscopy, as well as the NAS score and its components. And the secondary outcome looked at improvement in the liver enzymes and the cytokine profile. Now, after supplementation with the probiotic, these patients were found to have significantly decreased hepatocyte ballooning, lobular inflammation, and improvements in their NAS score. And within the NAS score, there were particular improvements in hepatocyte ballooning and hepatocyte fibrosis. The study also found that patients had decreased ALT, leptin levels, inflammatory markers such as TNF-alpha, interleukin-1 beta, a decreased concentration of endotoxins in the serum. Patients did not have any change in the parameters of metabolic syndrome or body weight, and there was no change in hepatic steatosis. All of the patients in the study who began with having SIBO, small intestinal bacterial overgrowth, had reduction and elimination of their SIBO. However, there were not enough patients to say if this was there wasn't enough power to see if this was a true effect. Now, two meta-analyses I have featured here that looked at randomized controlled trials for probiotics for fatty liver disease. And there are a few different discrepancies here, but overall, there does seem to be an improvement in liver chemistries, including ALT and AST, improvement in dyslipidemia, including total cholesterol, LDL, and triglycerides, inflammatory markers such as TNF-alpha, and also improvement in inflammation of the liver and histologic characteristics such as liver fat infiltration and liver stiffness. Now, if anyone has spent much time at all perusing the resources in AE ProBio, you'll find that all of us are very passionate about strain specificity, that just like you wouldn't walk into a doctor's office and ask for a medicine, similarly, each probiotic has different actions, and the strain and the particular mix of strains needs to be matched to the disease process for which it was studied. What seems to be true when it comes to NAFLD is that multi-strain probiotics do seem to have a better effect than single-strain probiotics, and particularly those with 3 or more strains. A couple strains and mix of strains that have emerged over the literature to be consistent and seem promising include some of these that I've listed here. The Dysbiosis D-Simone formulation being the one from the study I highlighted earlier. Interestingly, L. bulgaricus and Strep thermophilus, which are commonly found in yogurt starter cultures, do seem to consistently have benefit in NAFLD. And this does seem to be consistent with literature that looks at yogurt consumption in this patient population and finds protection against NAFLD as well as components of the metabolic syndrome. I've included some other strains that seem to be emerging as promising in the literature. And so to conclude with our learning on metabolic-associated fatty liver disease and probiotics, probiotics do seem to have promise in improving all of the parameters of the metabolic syndrome. Probiotics seem to be able to improve multiple aspects of MAFLD pathophysiology, including hepatocyte steatosis, fibrosis, local inflammation, and systemic inflammation. Multi-strain probiotics seem to be more effective than single-strain. And then hearkening back to what I was talking about meta-analyses and back to Dr. Quigley's talk, we do need more research to elucidate the most effective strains, the dosages, the durations, but at this point, we are beginning to see trends of strains that consistently do seem to show benefit. Now, moving on to cirrhosis and hepatic encephalopathy. Now, this is a figure from a recent paper talking about the pathophysiology of cirrhosis. And it talks about the 3 pillars of cirrhosis, the first being portal hypertension, the second being splanchnic vasodilation, and the third being bacterial translocation. And all of these components play a key role in the progression of cirrhosis and the decompensations of cirrhosis. Now, of all of these, we focus a lot clinically on portal hypertension and splanchnic vasodilation. I believe that the bacterial translocation aspect is more neglected compared to the other two. And this is potentially a role where probiotics can fit in. Now, just like for all other liver diseases, dysbiosis does seem to play a key role in the pathogenesis and progression of chronic liver disease, leading to cirrhosis. I talked about some of this before, but this is just yet another figure showing that metabolites from the gut microbiota can influence the liver in either positive or negative ways. Now, just like for NAFLD, there are changes that are consistently reported in cirrhosis with respect to the gut microbiota that differ from healthy individuals. And once again, these tend to be associated with increased local and systemic inflammation, small intestinal bacterial overgrowth, intestinal permeability, systemic endotoxemia, and inflammation in multiple organ systems. Now, minimal hepatic encephalopathy is a very frequent complication of end-stage liver disease. In fact, up to 80% of patients with cirrhosis experience minimal hepatic encephalopathy. Minimal hepatic encephalopathy increases the risks of hospitalization and even death. It's a risk factor for overt hepatic encephalopathy, which is one of the most common decompensations landing patients into the hospital. It increases patients' risk of falls. And there are even driving impairments associated with minimal hepatic encephalopathy. In fact, and terrifyingly, about 22% of patients with minimal hepatic encephalopathy may be committing driving violations. And so once again, there is a need not only from the individual health, but from the public health standpoint to treat minimal hepatic encephalopathy as it is a public health danger. Now, dysbiosis, unsurprisingly, contributes to hepatic encephalopathy. Specifically, a reduction in short-chain fatty acid producing species leads to a total reduction of short-chain fatty acids. These typically protect the gut lining and are anti-inflammatory. And so the reduction of these leads to increased intestinal permeability, which allows for the translocation of neurotoxic factors, which predisposes to the development of hepatic encephalopathy. Similarly, SIBO leads to local inflammation and increases intestinal permeability, once again allowing for the leakage of toxins and other metabolites that can reach the brain and promote hepatic encephalopathy. Reduced bile acid metabolism increases the permeability of the blood-brain barrier and increases neuroinflammation, which once again contributes to hepatic encephalopathy. And interestingly, looking at particular species, patients with cirrhosis tend to have an overabundance of Streptococcus salivarius, which as a metabolite produces ammonia, which is one of the metabolites that is associated with the development of hepatic encephalopathy. Now, theoretically, probiotics can target multiple aspects of the pathophysiology of hepatic encephalopathy. First and foremost, they can strengthen the integrity of the intestinal barrier. L-rhamnosus GG, for instance, has been found to decrease the serum lipopolysaccharide levels in patients with minimal hepatic encephalopathy. Second, they can decrease local and systemic inflammation. VSL3, this is actually the D-Simone formulation, was found to decrease inflammatory markers, including TNF-alpha, interleukin-1 beta, and interleukin-6 in patients with overt hepatic encephalopathy. And strains, including Bifidobacterium, Lactobacillus, and Lactococcus strains, seem to increase neutrophil production of reactive oxygen species, improving neutrophil function and decreasing infection risk. Finally, portal hypertension being that first pillar of the pathophysiology of cirrhosis, VSL number 3, again, referring to the D-Simone formulation, has been found to decrease TNF-alpha levels in patients with large esophageal varices, which are caused by portal hypertension, and decreased the gradient, which reflects portal hypertension beyond propranolol therapy, which is a beta blocker that is used to decrease portal hypertension. Now, looking specifically at studies, a 2017 Cochrane review looked at 21 randomized control trials and found that probiotics increase the likelihood of recovery from minimal hepatic encephalopathy, decrease the development of overt hepatic encephalopathy, improve quality of life, decrease ammonia levels. They seem to have very low occurrence of adverse events. And in this study, they were unable to tell whether or not probiotics were superior to lactulose. And there was no difference in mortality, even though there were improvements in minimal hepatic encephalopathy and the other improvements that I mentioned. There did not seem to be a mortality benefit. Now, similar to all other meta-analyses with probiotics, there was heterogeneity in methodologies, strains, dosages, et cetera. There was a high amount of bias, and the evidence was judged to be of low quality overall. A more recent meta-analysis in clinical gastroenterology and hepatology looked at 25 randomized controlled trials and tried to stratify the data in a slightly different way. And so beginning with the reversal, the likelihood of reversal of minimal hepatic encephalopathy, probiotics were found to be effective. When looking at rifaximin, lactulose, and probiotics, rifaximin seemed to be the best of the three options. However, when comparing the three head-to-head, there was actually no clear signal of one agent being superior to the other. For development of overt hepatic encephalopathy, probiotics were found to be effective again. And once again, there was no way to tell whether one of the options was superior than the other. In terms of mortality, just like the other trial, probiotics were not found to have a mortality benefit. However, neither did any of the other therapies for minimal hepatic encephalopathy. In terms of reduction in ammonia, lactulose was found to be effective. Probiotics were found to be more effective than lactulose, and probiotics were even more effective than the combination of lactulose and probiotics in the reduction of ammonia. In terms of adverse events, lactulose had the most adverse events, and this is something certainly that I see clinically all the time. Lactulose being a fermentable sugar, patients complain of tremendous bloating, distension, gas, and one of the reasons that patients come in for exacerbations of hepatic encephalopathy is often due to non-adherence with lactulose because of how uncomfortable it is to take. And then finally, with health-related quality of life, probiotics were not necessarily found to improve quality of life. Lactulose, however, did. Now, once again, looking at strain specificity, we don't have as robust data here as we do for non-alcohol associated fatty liver disease, but one paper in the Red Journal tried to look at the prior meta-analyses and refine the data a little bit. And what was found was that the following types of genuses and strains do seem to have a consistent effect. So lactobacilli as a class, bifidobacteria as a class, strep thermophilus, and then VSL3, once again referring to the D-Simone formulation. So in terms of strain specificity, these have consistently emerged as the strains and mixes of strains that appear to have the most benefit. So to conclude about minimal hepatic encephalopathy, probiotics are certainly effective in the treatment of minimal hepatic encephalopathy and the prevention of the development of overt hepatic encephalopathy. Certain probiotic strains and mixes of strains may be as effective for minimal hepatic encephalopathy as lactulose and are certainly better tolerated than it. Promising strains include lactobacilli, bifidobacteria, strep thermophilus, and the D-Simone formulation. Now, the last thing that I want to discuss is evidence-based probiotic resources. And this is something that I certainly have a passion about, and one of the reasons that I serve on the Scientific Advisory Council for AE ProBio is there is so much information and also misinformation about probiotics out there. And so it is extremely important as clinicians and as patients that we rely on reputable and evidence-based resources when we are talking, prescribing, or taking probiotics. And so, of course, the first resource I list here is the Alliance for Education on Probiotics, which has a website. It has the physical copy of the probiotic clinical guide that can also be found online. It's also an app. And then also the International Scientific Association for Probiotics and Prebiotics, ISAP, is another fantastic resource for all things microbiome and probiotics related. They produce beautiful infographics, such as this one I've included here on deciphering a probiotic label. And then, of course, reaching out to Dragana, to me, to anyone else on the Alliance or the Scientific Advisory Council, we are always happy to help further education on the science of probiotics. And so to conclude today, some key points are that dysbiosis underlies chronic liver disease. And so treating the dysbiosis can help prevent liver disease and even potentially reverse liver disease in its early stages before it reaches the irreversible stage of cirrhosis. Certain probiotics can reliably improve the parameters of the metabolic syndrome, which is one of the strongest risk factors for the development of metabolic-associated fatty liver disease. Probiotics can also improve multiple aspects of NAFLD, including hepatocyte steatosis, fibrosis, and inflammation, as well as systemic inflammation. Certain probiotic strains are effective for the prevention and treatment of minimal hepatic encephalopathy and are able to prevent the development of overt hepatic encephalopathy. And importantly, probiotics are better tolerated than lactulose, which is our gold standard of care. And so this is potentially an intervention that can help our patients adhere to their therapies and prevent the decompensation of hepatic encephalopathy, which results in significant morbidity and mortality and associated hospitalizations. We certainly need more research to figure out which strains and strain combinations are most effective and to figure out what doses and what durations are optimal. But at this point, there are some trends toward particularly promising strains. The Dysbiome D-Simone formulation does seem to be emerging both in NAFLD and for minimal hepatic encephalopathy as a promising option. And finally, multi-strain probiotics do seem to be more effective in chronic liver disease than single-strain probiotics, particularly when looking at the metabolic syndrome and metabolic-associated fatty liver disease. There are many other questions that need to be answered. There are lots of other liver diseases that are worth looking into with probiotics. This is, as Dragana mentioned, probiotics and liver disease is not new, but the enthusiasm has increased, the research is improving, the quality of it certainly is improving, and I am excited to see the development of research in this area, as I hope that all of you can take away that probiotics may be able to play an important role in our patients with chronic liver disease. And so I want to once again thank Dragana, the rest of the Alliance, for having me. To everyone who watched today, cheers to our gut and liver health. And at this time, I'm happy to take any questions.
Thank you, John. Amazing presentation. And again, so much information in such a short period of time. What's also interesting is, again, all disease begins in the gut. Gut is connected to everything. We knew about brain, and then now we know about liver, and there are probably more to come. We have interesting questions and comments in our chat box. So I'll just start reading them through, and then you jump in with any questions. There is, first of all, a question about whether slides will be available. The recording of this session will be posted in a few days on our website, and you'll be getting the notification of it. There is a question regarding choline. How do probiotics affect persons with a genetic predisposition that gives them an increased sensitivity to low choline intake, which puts them at a greater risk of NAFLD?
Yes, that's certainly a very good question. When looking at the TMAO pathway. The research there is very interesting because dietary intake of choline, most commonly from red meat, eggs, poultry, and fish, does seem to reliably increase levels of TMA and then the metabolite TMAO. And once again, this metabolite is considered a risk factor, or at least is associated with the development of atherosclerotic liver disease, as well as fatty liver disease. Now, what's interesting is that dietary manipulation of the gut microbiota can affect how much of this metabolite is actually produced. And so one elegant study looked at people who were eating meat, fish, and eggs regularly and put them on a vegan style diet. And what was found was that their levels of TMA and TMAO decreased precipitously and then returned to baseline once they reintroduced animal foods into their diet. And similarly, in a reverse of the experiment, people who ate a mostly vegan diet had very low levels at baseline, even when challenged with animal foods. But then their levels began to increase as their microbiota shifted to including a greater abundance of these microorganisms that produce this metabolite. And so this is one of the ways that probiotics can help. Dietary manipulation certainly seems to be a potent way in decreasing the levels of TMAO, but probiotics may be another way to do this by increasing the abundance of some of these beneficial bacteria, strengthening the epithelial barrier, and protecting against inflammation in the liver and systemically.
Thank you. Another question is, again, because you have lots of clinicians and practitioners, how do we practically and clinically suggest proper probiotic type/brands to patients when specific strains for each condition is not clear yet?
Yes, that is an excellent question. And honestly, that's the $1 million question. And literally, because people are spending millions of dollars to try to answer this question. And that's one of the main missions of AE ProBio and sessions like these, is to help answer these questions. Because you're absolutely right that while probiotics have been around for a while and the theory of manipulating the gut microbiota, our knowledge of what strains, what dosages, how long to use them, and for what conditions is much newer. And so right now, resources like the AE ProBio clinical guide are very helpful in guiding clinicians in helping their patients select the right probiotics. We, as far as I know right now, don't include much in the way of liver disease. I hope that, after this session, we can change that, and Dragana and I can certainly talk about that. But in terms of the other indications, such as irritable bowel syndrome, antibiotic-associated diarrhea, pouchitis, these are all well-studied indications that are included in the guide, and specific strains, brands, and dosages are recommended. And so as we have more information, we'll hopefully continue to make these recommendations more robust so that clinicians really don't have to look that far to make recommendations to their patients. And in terms of liver disease specifically, I think we have good models from the best high quality studies. And so I often turn to the primary literature myself and look to see what the exact protocols were as a helpful initial guide. And then as we get more robust data, we can codify that and help guide clinicians. So keep an eye on the AE ProBio guide is what I'll say.
Yeah. Again, just to add to that, we have had these liver conditions listed already with, I believe, 2 products only for the time being, because when we look at the research, we have to find out the commercially available product and to correspond to the indications in the guide. So check the guide. Another interesting question that is a very common question to many of the presentations. It sounds like you are recommending everyone, even healthy people, take a probiotic. Is that true? Which ones?
That's a very good question. It's a question I get asked all the time. It was a question I got asked this morning. I'm here in my clinic, which is why I have my stethoscope and white coat. I was asked one time this morning, and that's not an atypical question for me to get asked. So people may have different answers on this. I actually don't recommend that every single healthy person take a probiotic. I think that there are many ways to modulate the gut microbiota in a healthy way. And the most important, I think, and the most reliable and sustainable is through the diet. And so a healthy diet, and I'm happy to answer more questions about what, specifically that entails, but a diet usually including that's mostly plant-based, that is rich in prebiotic fibers, a diversity of these fiber types that includes lots of fruits and vegetables, nuts and seeds, whole grains, and that also does include fermented foods. There was a recent study that looked at the inclusion of fermented foods in the diet and found that participants who increased their intake of fermented foods had decreased systemic inflammatory markers. And so I think the diet is the most important way that we can support our gut microbiota. And then, of course, stress reduction, as things like anxiety and depression via the gut-brain axis can adversely impact gut motility and the gut microbiota. Spending time outside, making sure that we're avoiding a lot of synthetic chemicals. There are many ways to support our gut microbiota. So that raises the question of, who should take a probiotic? And what I always ask people is I turn it back with a question and say, who should take a medicine or who should take a vitamin? When I look at patients who come to me and have a skin infection, I give them an antibiotic for their skin infection, or when they come in with another condition that requires a specific medication, I prescribe that medication. And we need to think about probiotics in the same way, that each strain, each mix of strains has been studied for a particular indication. And so when people have a particular disorder, if they have metabolic associated fatty liver disease, that would be a great indication for them to use a probiotic. Dragana and I and Dr. Armstrong, who's giving one of the upcoming talks, recently published on the online GI journal, a compilation of the research and strains recommended for irritable bowel syndrome. And so I very commonly use probiotics in irritable bowel syndrome. So just like, do I need a probiotic? Do I need a medicine? What do I need the probiotic for? That's how I usually approach that question. So do all of the preventive things from diet and lifestyle. And if there's ongoing concerns, speak to your doctor about if they think that you have a condition that a probiotic may be helpful for based on the available evidence.
Perfect. And there actually probably brings us to, you probably answer some of the questions, what's your opinion about consumption of fermented dairy products to treat liver disease? Also, is there a particular probiotic brand that we can recommend to patients with the NAFLD compared to foods with probiotics like sauerkraut or kimchi? So I think you have addressed some of those questions. There is a specific question saying that the strain of bacteria 35624, which is for IBS, can this strain Bifo infantis help with fatty liver?
So I'll have to go back to some of the earlier slides to look at the exact studies. There are a few studies that look at bifidobacteria as a class. And this is, again, one of the challenges of the meta-analyses is that sometimes there are included studies where the exact strains aren't listed, which again makes it very difficult for us to interpret. And so I think in terms of metabolic associated fatty liver disease, at this point, we really should be focusing more on the strains that consistently have been shown to have benefit. And again, we're sort of at the beginning stages of this, but as I mentioned before, there are strains and combinations of strains that are consistently emerging from the literature as helpful for this condition. And so I think that we are best off to stick with those as opposed to single studies that look at a probiotic or a probiotic combination. So we should stick with what most of the evidence says.
Also, there's a question about your thoughts on hygiene hypothesis, killing our microbiome, like sanitizing, overuse of dishwasher, etc.
Yeah, I think there's a lot of truth to aspects of the hygiene hypothesis. I mean, even studies that look at generations of immigrants, and one study comes to mind of people living in Thailand, and the first iteration of the study was culturing the microbiota of people who live in Thailand, and found that there was an abundance of healthy gut flora, of short chain fatty acid producing bacteria, and there were a rich diversity, very little presence of pathogenic species. And then it studied people who came from Thailand and emigrated to the US, and found that after a few years, there's a decrease in diversity in the gut microbiota. There's a slight increase in the abundance of pathogenic species and of these toxic metabolite producing species. Then it further compared these with their own children, and found that they had an even further reduction and even more dysbiosis. And then finally, the last comparator was people who have lived in the United States for generations, whose families generations back had originated in Europe, and found that they had the lowest diversity, had a very high abundance of these pathogenic species, very low concentrations of these short chain fatty acid producing bacteria. And so that's why I do like to talk so much about the preventative aspect of having a healthy diet, of spending time outside, of controlling stress, trying to minimize the use of medications that can adversely impact the gut microbiota when possible, because all these things certainly do have a tangible impact on not only gastrointestinal health, but systemic health.
Another question is that you mentioned that dosing duration still needs to be determined, but in general, how long did most studies follow their patients? Are these promising results developing over the course of days, weeks, or months?
Mm-hmm. That's a very good question. And studies do vary a little bit. And so looking at the probe and the Promagin styles, for instance, for the Lab4P probiotic in obesity, those studies were performed at 3, 6, and 9 months. Some of the other metabolic associated fatty liver disease were on the order of months to a year, and the hepatic encephalopathy ones were on the order of weeks to months as well. However, all studies have to end at a certain point, and when looking at hepatic encephalopathy, remember that cirrhosis is the irreversible stage of scarring of the liver. And so for any of our patients who present with the decompensation of hepatic encephalopathy, we are always treating their hepatic encephalopathy, because when they are not adherent with their treatment, they are likely to develop hepatic encephalopathy again. And so this is an instance where it may be good to continue these patients indefinitely, because that's what we're doing with our other therapies, such as lactulose and rifaximin.
Okay, there's a few questions about the short chain fatty acids and which one has the most beneficial effect on the liver disease, acetate, propionate, or butyrate.
I don't know that we can say that one of the particular acids is more important than the other. Certainly a majority of the studies that measure short chain fatty acids either measure one or all of the short chain fatty acids. So I really don't think that we can say that one is more important than the other. And one of the benefits of enriching the gut microbiota with these short chain fatty acid producing bacteria, whether that's via the diet or via probiotics, is that there's a diversity of species such that we can attain a higher concentration of all of these short chain fatty acids, which do seem to have multiple benefits for luminal and systemic health.
Great. And we are getting some comments as well that eggs and fish, especially fatty, omega-3 rich ones, can be part of healthy diet. Avoidance might not be necessary, and it's more important to include high fiber foods, legumes, vegetables, fruits, and whole grains that will help microbiome. I think we have addressed.
I think, when people ask me sort of what the most important component of the diet is, it's sort of a hard question to answer because it's really the entirety of the diet that is important. But I think if we did have to pick one particular component of the diet, it really would be the inclusion of a diverse range of fiber-rich foods. So fruits and vegetables, nuts and seeds. These I always say that fiber is fertilizer for the good bacteria. And so I really think that these fiber-rich fruits and vegetables, legumes like lentils are some of the nutritional powerhouses that reliably and sustainably enrich our microbiota.
That's excellent. I think I should put the plug in for Canada, because I believe Canada is one of the biggest exporter of the lentils and pulses and chickpeas, etc. So yes, those are excellent foods. There's a question about what yogurts do you recommend for NAFLD disease?
Yeah, it's a good question. As you saw, some of the trials looked at yogurts. And so in yogurts, and this is actually something that Dragana and I were talking about peripherally on Twitter the other day, homemade yogurts tend to have a higher diversity, abundance, and colony-forming units of a lot of bacterial strains due to the lack of processing. And also when you buy anything from the shelf, there's some degree of processing, and there's shelf life as well, that can decrease the concentration of live microorganisms that you're getting. Now, what does seem to be consistent is that L. bulgaricus and Strep thermophilus do seem to be consistently associated in observational studies, at least, with a decreased risk of metabolic associated fatty liver disease and other components of the metabolic syndrome. And these are strains that are typically found in most yogurts that include live cultures. And so I am a big proponent of the inclusion of fermented foods in the diet. I usually don't specify particular yogurts as long as it's not flavored with lots of artificial sugar or high levels of sugar. Generally, I'll just recommend yogurt in general. And there are also, for those who avoid dairy for any number of reasons, there are also a lot of dairy-free yogurts, including from soy and almond and coconut bases, pea protein. Even recently I saw that also do include live strains. Again, it's hard to tell how much we're actually getting in there, but I do advocate that these patients do regularly consume fermented foods.
I know that we are kind of running low on time, but I'll plug a few more questions that are coming in. Another one is more specific. It's a phase angle cell inflammation assessed in any studies looking at effect of probiotic/chronic liver disease?
That's a good question. I haven't seen any human studies that look specifically at that aspect. At least in my research, there may be something, but not that I've seen. I tried to look pretty broadly so that I wasn't missing anything, at least in the human studies. But I did limit my research to looking at human studies, since it's the most applicable. So there may be preclinical studies that assess that.
That's good. Also, there's following on that, are probiotics good in reducing inflammation in chronic kidney disease?
So there is interest in probiotics for chronic kidney disease. Some of this relates in the preventative aspect to hypertension and diabetes, for instance. And so hypertension and diabetes are two of the most common causes of chronic kidney disease and the eventual development of end-stage renal disease and the need for dialysis and transplantation. So whether from hypertensive nephrosclerosis or diabetic nephropathy, once again, there is a tremendous public health need to intervene early to prevent these complications, as end-stage renal disease and dialysis portend a tremendous financial burden on our patients and our healthcare system. I don't know as much in end-stage renal disease. I know there are a few studies that have been promising, finding that there does seem to be a decrease in the presence of uremic toxins in patients with end-stage liver disease, which is very encouraging. And then, of course, some of the research I mentioned earlier from both the diabetes and the hypertension standpoints.
Absolutely. And we've been monitoring and following the product as a combination product. We are hoping to see more studies to actually include that in the guide. So there are two questions. One I will answer. Should everyone taking antibiotic be recommended a probiotic, and which ones? Those are listed in the guide, but I would say maybe you answer if everybody should be taking a probiotic with antibiotic. That will be one question for John, very briefly, and then I'll conclude with the last question.
Sure. And then I would say that that's another $1 million question. I'll try to answer briefly, but I think there is evidence that it can be helpful. There are multiple strains in the guide that have reliably been shown to decrease the risks of antibiotic-associated diarrhea. There were a few studies highly publicized recently that raised some concerns about taking probiotics at the same time. But I think on the whole, my practice is I still do recommend that people do take probiotics when they are on an antibiotic. We do know that it does decrease the risk of antibiotic-associated diarrhea, and there are some other benefits as well. So we do need more research to really clarify and clearly nail down this question. But for now, I don't think it's unsafe for people to take probiotics while they're getting antibiotics.
Absolutely. And I had a pleasure to speak with a few researchers, Dr. Reed, one of them, that have mentioned that there's I would say, preliminary evidence that probiotics might actually help effect of antibiotic at mucosal sites. So there might be additional benefit if the probiotic is given with an antibiotic. And again, because we are at top of the hour right now, and I would like to thank John for taking time, but there's one question that is also on top of my mind. Is there a relation between artificial sweeteners and microbiota? Do you recommend them to lower dysbiosis?
That's a very good question. And I gave a talk recently on diet and the gut microbiota. And interestingly, there really isn't a tremendous amount of research in humans. So there does seem to be preclinical evidence that finds that certain artificial sweeteners may adversely impact the gut microbiota and adversely impact insulin sensitivity. However, there are others that don't. And I think part of this has to do with the fact that there are many different artificial sweeteners out there, that Splenda may have different effects compared to stevia, for instance. And so I think there are still a lot of questions that need to be answered with respect specifically to the effects on the gut microbiota. Now, I think a valid question that often gets asked is, are these artificial sweeteners good alternatives for just sugar? And I think that that's another question that does need to be answered. And I've asked several of my nutritionist friends this, and I think generally due to what we know about the effects of sugar on the gut microbiota and on systemic health, the reduction of sugar, which is something that our government is certainly aggressive in working on because it is a public health issue, that reduction of sugar, especially refined sugars, is an important part of a healthy diet. And so patients may be able to use artificial sweeteners in a way that helps them wean off sugars. And an analogy to this might be electronic cigarettes. Obviously, as a physician, I don't recommend that anyone vapes or uses electronic cigarettes. However, the FDA is moving to approve electronic cigarettes as a smoking cessation aid. And many of my patients have successfully used them to help them stop smoking. So that's kind of how I view artificial sweeteners. Probably not the healthiest thing that we can do, but especially in patients who are at risk of metabolic syndrome, if they're able to use these products as a way to help them decrease their refined sugar intake, then that is something that we should encourage.
That's great. Thank you so much, John. It's amazing what we learned tonight. The question about the kidney health is another most likely a topic for a whole series of educational sessions. So today, again, I'd like to thank you for clarifying many questions. And one of the interesting questions that comes to the liver health is the question about, you mentioned that VSL number 3 and Dysbiome or Dysimone formulation that has kind of created lots of, I would say, misconceptions and confusion. So what has been published as VSL number 3 until 2017, I believe, it's now referring to the formulation called Dysimone formulation, or also known as Dysbiome. So that's kind of clarified in the guide as well. So on behalf of the Alliance for Education on Probiotics, I would like to thank Dr. Damianos for sharing insights and expertise with us and your time away from your clinic, from your patients. I'd like to also thank Exegi Pharma for funding this event and for all of you for joining us. So please remember that the clinical guide to probiotic products, US and Canadian versions, is always available for you in print, online, and through a smartphone app, which is free to download. And again, make sure to visit a probio.com website that John mentioned a couple of times, as often as the new content is constantly being added, including this session and previous sessions. Dr. Quigley's session is already there. They are recorded and are available to view at your own leisure. And again, finally, we like to remind you that we are here to support you. We strongly encourage you to complete our post-event survey to provide your feedback on this session and let us know what topics you would like to see explore in the future. And again, thank you again for joining us. And this concludes our session.